Good afternoon, and thanks for joining us for today's Healthline 3. I'm Courtney Butts. Today's topic is sports medicine, and joining me today to talk about this is orthopedic surgeon Dr. Mark Callahan. Thanks for joining us.
Absolutely. Happy to be here.
Absolutely. So tell us a little bit about what you do as an orthopedic surgeon.
Yeah. So I'm an orthopedic sports surgeon, and I think, again, the misnomer with that is thinking that it's only athletes that we treat and stuff like that. I will say we do have the privilege of taking care of a lot of the high schools in town. I see a lot of high school and young age athletes that are still doing competitive athletics and some college athletes and stuff like that. But there's also a large subsegment of our practice where it's, more the weekend warriors or even just people trying to do their job, trying to go out and do hobbies, things they like, live life. If they wake up with shoulder pain, they wake up with knee pain. I mean, those are also things that we see and treat in clinic. It's not just people that are, young, healthy, athletic individuals.
Right. Okay. And so, were you an athlete at one point? Is that kind
I was.
of how...
I did grow up playing sports. It was big on my thing. I was from a little bit colder climate, so hockey was my big thing actually. So we got the mud bugs down here, but yeah. I grew up playing sports. I think that's part of my interest, and I will also say, when you're thinking about the younger side of our patient population, the actual competitive athletes, that is one of the gratifying things, being able to take these kids from a point of injury and kind of a low point, dark point, get them back, and makes it worthwhile seeing them get back happily to the sports and stuff that they want to do. I mean, that's definitely one of the big parts of the job that we appreciate.
Cool. So you're an orthopedic sports surgeon, so you kind of have that specialty within the sports
exactly.
medicine.
And so a lot of sports medicine is minimally invasive surgeries. So I mean, on my older patient populations, we'll do a lot of arthroscopic, meaning little poke holes in the camera, specialized equipment to fix like rotator cuff tears, labral tears, biceps issues. We can scope knees and clean up what's called meniscal tears, the little shock absorber disc in the knee. And that's kind of what we do from a minimally invasive standpoint. But then as far as bigger surgeries go, I mean, we do a decent amount of trauma work. So if people fall, break collarbones, break upper extremities, stuff like that, we'll fix. If I'm on call and you fall and break a hip, we'll still fix those things too. So we do a lot of bread and butter trauma stuff that traditional orthopedic surgeons do. But the sports is more focused on kind of shoulder, knee, elbow issues, a lot of minimally invasive, but also, as we talked about earlier, non-operative stuff if we can. Injections, non-operative stuff, physical therapy, all those things that we can get you better with.
Yeah, for sure. Because like we said, surgery can kind of be a little scary.
It can. And I think that's where I try to put patients at ease. If you come in and you have a problem where I'm saying, hey, structurally, this thing is too much of an injury where it's not going to be worth your time, we're going to be spinning our tires if we try to go the non-operative route, I'll let you know, if it's really that bad enough where you're just not going to do well outside of surgery. But if you come in and it's an area where we're saying, hey, this is something that we could probably get better without doing surgery, or there's a good chance we get you to a point where your quality of life is good enough where you're not looking for any other treatment, that's always my goal. So I let people know, look, I'm not just trying to shake your hand and sign you up for surgery.
Right.
I want to get you better, and if I can get you better without cutting on you, that's always going to be the goal.
Absolutely, yes. And as a reminder, Healthline 3, which is what we're doing right now, is where we like to focus on ways to live a healthier, happier, and pain-free life. And so we'll be taking your calls and answering your questions live in the studio today, and Dr. Callanan will be answering those questions. We'll be opening those phone lines soon, but as a reminder, when you do call, make sure you're in a quiet room with that TV turned all the way down so that we can hear your question. And that number is going to be on your screen. It's 318-219-4569. But in the meantime, if you have a question, please give us a call. But I'm going to be asking my own questions as well. I've already kind of started. So tell me a little bit more about like sports medicine, just in the traditional standpoint when you think of like athletics.
Yeah.
So kind of what does that encompass?
With our athletes, I mean, sports medicine is really the treatment of anything related to sports injuries. And that can be from overuse, that can be, we're in football season now. Obviously, there's a lot of traumatic injuries that happen. So, just taking football for an instance, one of the big things we see right now outside of, the sprains and strains and everything else, contusions, bruises, we see ACL tears, you're tearing ligaments right now, we see shoulder dislocations, we see clavicle fractures, wrist fractures, hand fractures, all these things. So certainly from the trauma standpoint, we're treating bone and musculoskeletal injuries related to sport. That's really the sports medicine side, and we're trying to do it as minimally invasive as we can. And that's where, the fellowship training in sports is really emphasizing on the minimally invasive treatment of these things.
Yeah.
And that's really from the younger populations from sports, but also the encompassment of kind of everything else we do. If you're thinking about my older patients, rotator cuff tears are very common in the United States. We do tons of rotator cuff repairs and treatment of those. I do shoulder replacements too. That all falls into the auspices. I'm kind of A to Z on shoulders, so the whole spectrum will treat. And then same thing with knees. You know, we can do everything from just simple scopes, cleaning up meniscal tears, fixing meniscus in younger populations, reconstructing ligaments, even to some fancy cartilage procedures. You know, if you overall have reasonable cartilage, you're a young enough individual where it's not just arthritis but an actual trauma, I can take a cadaver, you know, a dead person's live cartilage, freshly harvested, and we can implant that in your knee to kind of fill in the blank. I can harvest some of your own cells, we can culture them in a lab, and then basically make a film of stem cells that I can implant in to regrow some of that cartilage. So there's also some kind of sports techniques in very specific and indicated situations that we can utilize from that standpoint.
That's really cool.
Yeah.
Yeah, so a lot of advancements you've probably seen over the years, just in, you know, being in practice with, I mean, the implant, the cartilage implant. That's pretty interesting.
Yeah.
So I'm sure, you know, it's football season. When you watch football, we were watching the LSU game on Saturday night, I'm sure as many people were, and, you know, a lot of people got injured, I feel like, during that game. And so you can just watch a game and you can probably guess what's going on.
Yeah, I'll have, it's funny because I'll have people text me sometimes. My dad, when he's watching football or anybody, you know, they'll reach out and say, hey, what do you think that was? You know, and even some of the guys I did fellowship with, we have our own text chain where, you know, somebody goes down in a big collegiate game, you know, when Bama's playing Georgia or something like that, everybody throws out their theories based on what we saw, kind of the mechanism, kind of what the injury is. So it is kind of fun from that standpoint. I had the privilege when I was a fellow of actually covering Auburn. And so, you know, I sideline them and you get to kind of see firsthand when those things are happening. It can be somewhat chaotic, but it's so well managed, and, you know, seeing the injuries at different levels has been great in my training.
Okay, yeah. And so you mentioned ACL tear. I'm sure that's really common.
Yeah.
You know, and is that something that you have to have surgery with, or?
My spiel on ACLs, and anybody that's ever been would probably laugh because they've heard this thing before. You know, do you need an ACL to survive? I always tell people no. You know, years before we were ever reconstructing for the last couple centuries, people are falling off horses, they're tripping in ditches and stuff like that and tearing ACLs all the time. Is it something that you just can't function with? The answer is no. But if you have somebody that's an athlete that is young and likes to do running, cutting, pivoting sports, sure, day-to-day stuff they can do fine, but the second they try to expand on that and try to do more explosive maneuvers, they're not going to trust that knee. They're going to feel that knee shifting around. They're not going to be able to be the athlete, be able to get the power, and they'll even tell you it feels like it's slipping or it feels like it's sliding around, and that's just because it doesn't have stability. So in young, healthy athletes, yes, we almost universally say not just to get you back to sport and play, but you're going to eventually maybe have kids. You're going to be doing recreational hobbies. You don't want to be that guy that has to rely on a brace forever. And even there's certain studies where they looked longitudinally at people that had torn ACLs when they were younger and didn't have these things reconstructed. If you go a couple decades of that knee sliding around, having some inherent instability, all the other structures in the knee kind of take abuse. You start breaking down the meniscus, the cartilage wears out. People tend to get a little bit arthritic quicker when they've had chronic instability. So that's also the argument for preservation. You know, when these athletes are so focused on the season, I'm saying that's great. We want to get you back playing, but at the end of the day, you got to think 20 years down the road. You want to be that guy that's already getting a total knee when you're in your early 40s.
Right, and when you're younger, I feel like having that surgery, it's probably an easier surgery.
Yeah, I would
if
say
you were
so.
older.
And I will tell you that, you know, ACL reconstructions, you know, if you come in and you're 80 years old, it's probably not something we're going to recommend, obviously. But I've had patients up to, you know, in their 50s and otherwise that have been off on vacations, downhill skiing, that will tear ACLs. There's a little bit different graft that we use to reconstruct that. But if you're healthy and active enough, you don't have a, you know, arthritic knee, and you like to still get after it with certain sports where you would require a stable knee and you don't want to wear that brace, we'll still do ACL reconstructions up into our middle-aged populations too.
Right, and so we were also talking about rotator cuff tear. I feel like that's pretty common in the older population.
Yeah,
as
exactly.
well.
The rotator cuffs are something I don't tend to worry about till you're 45 and up population. When I get a high school student that comes in and they've either had a dislocation or they're having shoulder pain, it's almost, you can get rotator cuff inflammation and tendonitis. It's rare to get a tear in those young populations, or really anybody under 45. It's rare to see a big full thickness tear. Those younger high school athletes are usually labrum, which is kind of the rim of tissue surrounding the socket. It's a little bumper. You can imagine with contact sports in particular, it can get beat up. Our volleyball players going up for those big spikes. There's different things that you can do to injure that. So that's a little more common in that population. Rotator cuffs, though, that tends to be my populations where people in their 50s and 60s, most of them don't even have a story where, hey, I picked up something heavy, I had a fall. It's like I woke up one day, this thing was bothering me, I didn't think anything of it. Fast forward a couple months later, they're like, this is getting worse, and they're sitting in my clinic. And that's when I'm immediately thinking, hey, I'm having a hard time reaching away from the body, reaching overhead. That all kind of speaks for rotator cuffs. So those are the more classic kind of what we call insidious onset of shoulder pain patients that I'll see, and it tends to be a little bit older population.
Okay, so it seems like maybe you don't do something as drastic like when you're hitting the volleyball. When you're older, it just kind of builds.
Exactly.
Okay.
Some of it is more degenerative versus the traumatic.
Okay.
All right. And so I think when it comes to rotator cuff tears, you'll certainly have the traumatic ones, the slip and fall, somebody picking up something too heavy, they feel a pop in their shoulder. That's probably more the rarity. I think a lot of them, when it comes to it, are just the insidious onset. And there's a lot of different theories and a lot of different reasons that people will develop rotator cuff tears. Degeneration of that tendon, though, and to take a step back, when everybody says rotator cuff, and a lot of people have heard this term, most people are kind of like, I don't know what the rotator cuff is. Everybody calls it the rotator cuff and stuff like that when they come in. It's actually a collection of 4 muscles that attaches from your shoulder blade. They reach over and they attach on the front and the outside of the ball, and they facilitate that normal shoulder motion, the reach and grab and push and pulling. So just by living day-to-day life, there's some wear and tear that starts from day one with that tendon. It can rub up under the acromion, which is the little roof of bone above it. Even different things like working out, different stresses and strains, you can create little micro trauma on that tendon. The blood supply is not amazing to the rotator cuff, so at the end of the day, it doesn't have an amazing propensity to heal itself. That's why a lot of times people may develop these little partial tears they don't even know about because the body can compensate. And when they wake up that one morning, they start having shoulder pain, it's more a sign that the body's saying, look, this is getting beyond the small little tear we can't compensate for. This is now becoming a problem. And that's when, people start showing up to my clinic.
Right. Okay. Makes sense. Yeah. Thanks for explaining that. Same thing with maybe an ACL. I think a lot of times we hear that and we don't really know how it's stabilizing, your knee. But really interesting to have that explained about the rotator cuff, the 4 muscles, and how you have that degeneration over time.
Absolutely. So that's one of that's probably the primary thing I see as far as shoulder complaints, statistically the most likely. You do have the long head of the biceps tendon, what actually comes up along the front of the shoulder, does a 90-degree turn, kind of wraps around the head and attaches at the top of the socket. So it's a very interesting design, but it's kind of an intricate relationship with the rotator cuff itself. So a lot of times if you have a little bit going on in the cuff, you'll have some biceps issues as well. So they kind of go hand in hand for most patients that I see. Yeah.
And so we're also talking about in addition to the bones and your joints and ligaments, but also muscles. And so would you say that a preventative measure would be physical therapy or doing certain types of exercises?
I think there's a lot of good prehab that you can do for shoulders. We have a little handout that we do of a lot of basically isolating rotator cuff specific exercises. I think imbalances and weakness in the cuff can certainly contribute to the development of shoulder symptoms. So when you actually think about what a physical therapist is doing, they're kind of breaking you down with their assessment to say, where do we have a lack of movement, some tightness on here? Where do we have some weakness? How can we adjust this to try to optimize the mechanics of the shoulder? And that way you're not just throwing medications at it. You're not just injecting it with steroid, you're not just throwing pills at it, you're actually kind of correcting problems so that when you're moving forward, it's ideally not a recurring issue for you.
Absolutely. Okay, and so we've talked about knees a little bit, shoulders. You also mentioned elbows is a common thing that you see. Okay.
Elbows are very common. So tendonitis, especially when you think about tennis elbow or golfer's elbow, people hear these terms. Lateral epicondylitis and medial epicondylitis are probably the 2 most common things I see. And I will say that, from a technical standpoint, those are just the fancy way of saying tennis elbow, which is on the outside of the elbow, or golfer's elbow on the inside. Now that being said, a lot of people will have lateral elbow pain. They come in and I can almost, immediately when they start telling me and kind of pointing, I know exactly what it is. a small fraction of people are actually playing tennis when they get tennis elbow. It's an overuse thing, just like anything else with a cuff. You're out there, you're doing yard work, you're gardening, you're doing everything you want to do. You can certainly develop wear and tear within that tendon and inflammation, and every time you're gripping something, picking up your coffee in the morning, turning doorknobs, you're having pain. That's tennis elbow, basically, or epicondylitis. So those are things we commonly see. A little bit less common, but not infrequent. I have guys that come in, your distal biceps actually attaches just past the elbow. We see not an insignificant amount of biceps ruptures, tends to be more in my adult male populations, either at the gym if they're lifting something too heavy or doing yard work, trying to pull a big tree, they feel a pop. I've had a gentleman one time, he didn't deploy the kickstand on his motorcycle and try to save it from going down, felt the pop. So, those are things around the elbow that we'll see. And then in addition, every once in a while you get loose bodies or stiffness and different things where I can actually scope an elbow and clean out the joint, take out loose bodies, different things like that, release some of the capsule, try to get people more motion if they get post-traumatic injuries. And then as far as our group goes, a lot of the elbow fractures and stuff kind of get referred to me, so we'll take care of a lot of traumatic stuff too.
Gotcha. Yeah, very, very interesting. Yeah, we've all heard tennis elbow, golfer's elbow, but it's interesting that most of the time it's maybe more normal wear and tear.
Exactly.
Yeah.
Exactly.
Gotcha. Okay, well, if you're just joining us, we have our phone lines open, 318-219-4569. We're talking about sports medicine. We're talking with an orthopedic surgeon, specifically, talking about maybe surgical methods and preventative measures as well with Mark Callanan. If you have a question for Dr. Callanan, just please give us a call. That number is right there on your screen. Okay, so also we've talked a lot about like trauma with as far as like athletes, getting hit and then something tears, but what about for someone long-term, like arthritis? Explain kind of the differences between like something that is sudden versus a degenerative
kind of
buildup.
degenerative.
Yeah.
So yeah, that's a good question. And I think that a lot of it when I'm assessing people, if there's no trauma associated with it, if it's my, older adult populations when they come in, there's almost inevitably some degree of arthritis. So some of the art form is trying to flesh out how much of this is related to baseline arthritis a patient may have, which arthritis in general, if you're saying, well, what's that actually defining? Well, it's how much cartilage loss just from wear and tear, living life that you have within the joint. I think there, certainly is some hereditary genetic component. There's some families where it's like everybody has had all their joints replaced, and I do think that is more in the degenerative side of things, where just from living life from day one, you start walking, you're beating on those cartilage surfaces, and just like anything else, tires on a car, there's a shelf life, and it will wear out over time, some people quicker than others. And then where the trauma component comes into play, that's always one of my questions when I have a patient coming in with either shoulder or knee pain. It's, okay, is this the first time you had it? Have you had any big traumas in the past? If you get guys that played football when they're younger, sometimes they're like, yeah, I had a bad injury, they just told me walk it off type thing, and I've just always had a little bit going on. And so okay, there was probably some degree of trauma that wasn't treated early on. That can contribute, but honestly, there's a lot of people without any history of trauma that will just come into my office. We get x-rays, you can judge how much arthritis they have. Sometimes they're pretty advanced, and I say, look, from my standpoint, there's not a lot we can do with the scoping and everything. We can try the conservative stuff, injections, medical management with anti-inflammatories. If they're stiff, do a little bit of therapy, but at the end of the day, they may be more treated better with metal and plastic, getting a joint replacement done.
Right. Okay. So speaking of joint replacement, do you do maybe more knees and shoulders and some hips?
Yeah. So I will say the hips that I predominantly do, because I got a lot of great partners that only do hip and knee replacements. There's a lot of guys in town that will do just joint specialists. They're typically known as just arthroplasty surgeons. Most of them will predominantly have a practice of just doing hip and knee replacements, and I have several partners like that. So really, for a lot of the elective arthritic hips and knees, I refer them to my partners. If I'm on call and somebody breaks a hip and they need a partial hip replacement, absolutely we'll take care of that. That's the other kind of geriatric side of things. We'll fix hip fractures. I'll do replacements in that setting. But as far as the shoulder, I do A to Z on the shoulder. I do a lot of replacements on shoulders. Shoulder arthritis is not as common as hip and knee arthritis. We don't walk around doing handstands all day, so we're not loading the shoulders like you do for hip or knee. So, but it does happen where you guys got males and females that have been active their whole life, had active jobs, labor-driven jobs, Construction workers are prone to this, people that work out on oil rigs and stuff. I see a lot of that where shoulders wear out like anything else too. So you can certainly get advanced arthritis. And I will say when it comes to shoulder replacements, this is not getting too far into the weeds, but there's kind of two different varieties. There's kind of anatomic total shoulder, which is resurfacing the ball and socket. So if you overall just have some arthritis in the shoulder, you're usually a little more younger patient, your rotator cuff is intact, you've got good strength, but just a lot of pain from the arthritis, we can just basically resurface that ball and socket. When you have patients that are a little older, where not only do they have arthritis, but they also have some rotator cuff issues, or let's say I get a patient that has had a prior rotator cuff repair, or we get the imaging, I can tell that this tear is chronic. This thing is very retracted, the muscle is shriveled up to nothing. It's probably not repairable. Traditionally, we just used to say, hey, you can get injections, you can just live with it. There's not a lot we can do from a salvage standpoint. But now we do what's called reverse total shoulder, and that's where we can switch the ball with the socket. So ball goes where socket is, socket goes where the ball is. It was actually developed initially in Europe, and we kind of watched it, I think, for about a decade. I don't want to joke too much about the Europeans, but they're our favorite test animal, as we like to say in the medical field, because a lot of stuff we adopt. We see how it works over there, and if it has good outcomes, we bring it over here. So I think reverse total shoulders are probably done more in the United States now because there's a little bit broader indication. Patients do well. A lot of people have chronic issues with their cuff or had recurrent tears that are not fixable, and it's a good solution for pain control and for getting back function. And that's where I think, for many populations, they have a little bit more than just arthritis in the shoulder, so I probably do more reverse total shoulders than anything.
Yeah, very cool. So one thing that was very interesting that we briefly touched on was kind of those advancements, the cartilage implants and those types of things.
Yeah.
I think that's really interesting. If you want to tell me a little bit more about when that's indicated and how often maybe you do that.
Yeah. This is always the emerging field within orthopedics, and I think anybody that discovers the Holy Grail would be like, who can truly regenerate cartilage, especially when you're talking about arthritic knees. When somebody comes in, if they have too much arthritis or they're going down that degenerative pathway, you can't really offer them much of a cartilage procedure. They're more just generalized wear. It's just not indicated. But if you have younger populations, especially with traumatic injuries, sometimes with ACL tears, that violent kind of shifting mechanism when that ligament tears, you can knock off a pothole of cartilage. Or even without tearing a ligament, trauma to the knee, I've seen people knock off large chunks of cartilage. You can, on some occasions, go in there if it has enough of kind of a backing and it's viable, and literally just repair it back to where it popped off. You can use some headless screws, there's different things like that. But in situations where it's chronic or not fixable, that's where you can use, fresh cadaver plugs, which is literally somebody, usually within the week or so, that has expired. So you actually have live cartilage cells that are harvested quickly in these little plugs. And it's almost like a pothole in the road. You can core out that area. If it's a certain size, you can order a certain size plug and you can implant that. And there's viable cartilage that you can ideally get some bony ingrowth and actually have just real, genuine cartilage cells.
Yeah.
And that's for smaller defects. When you have bigger defects, there is a procedure, if indicated, especially in younger populations, called the Macy procedure, where you can actually biopsy the cartilage. You can grow it in a lab based on the size. There's a certain amount that they'll grow, so that's kind of the lead time to do the second procedure. So you biopsy the first time, get an idea of the lesion size, culture these things, and then you can come back in with this film where they implant all those stem cells and actually more or less glue it within that spot, and it will actually generate new cartilage cells. They basically regrow their own cartilage. And so that's a good procedure. And we're always trying to push the advancements, in particular with cartilage and the use of biologics and stuff in orthopedics. I would love to tell you that we have the perfect solution with stem cells and all this. We're working on it, but there's really just not a lot so far clinically that's been shown to make a huge difference. So that's kind of the next frontier, I think, of sports medicine in particular.
Stem cells specifically. So tell me a little bit about, for our viewers that may not understand the difference between how does stem cell therapy, what does that look like?
So I will say, when you're thinking of common biologics, there's platelet-rich plasma, which is known as PRP, that a lot of people will use. We probably have the most literature on that as far as all the biologics that we use. What that is actually drawing a patient's own blood. You have to take about 60 cc's, which is a decent amount of blood. There's a special centrifuge that we know from testing and everything. We can spin it down and actually get a portion of concentrated platelets and kind of the healing factors that spins out of that. And that's what you inject back in to either either the joint, so for arthritis, there's actually some good literature for arthritic knees as an alternative to like steroid injections, or what we call hyaluronic acid, or rooster comb injections, as a lot of people call them. Platelet-rich plasma is kind of a natural biologic alternative that's shown, a little bit more durability in some studies, out to 6 months or a year, compared to just a standard steroid injection. So I do think for arthritis there's some indication, but also when we were talking about tennis elbow, that's one of the other good indications for platelet-rich plasma compared to a steroid injection. It's a little bit more durable. Ideally, there's a little more healing that goes in there. It's more or less a biologic anti-inflammatory, though, is what I tell patients. Now, the flip side of these things is insurance is still not quite on board with them. Okay. So a lot of it's an out-of-pocket cost. And that's why when we're talking about kind of the other side, stem cells, it sounds good. The stem cells that we can kind of legally use in the United States are typically derived from bone marrow aspirate, where you can go in and usually take it from the pelvis or one of the long bones, basically spin it down, have this concentrate of bone marrow stem cells that you can inject, with the idea being, if you have these stem cells that are still kind of what we call pluripotent, where they can change into a bunch of different things, then ideally put them in there. They help regenerate some of the tissue. That's kind of the very basic idea. With pretty much all the studies we have, there's some that have shown some promise, but a lot of them have not shown enough benefit where the cost of doing these procedures and injecting these things. Now, don't get me wrong, if you go to Dallas or any big city, you'll find somebody that will certainly offer that service, and some people swear by it. But as far as literature goes, it's one of those things we just don't have enough yet where insurance is covering these things. So there's usually a pretty big out-of-pocket cost just based on the kits and the procedure and everything else that goes into it. Yeah. But I will say, as far as other stem cells go, there's some fat-derived ones where people actually, was developed by a plastic surgeon. Initially, it's almost like liposuction. And you can break those down, and there's actually some stem cells within the fat cells in the body that you can break down and inject those back in. And so that's another popular one in the U.S. And
the stem cells and the PRP, they kind of, again, that healing factor is what we're
That's
going
the idea
for.
behind it.
Okay.
I think PRP, there is some healing. I think, again, it's more of just a biologic anti-inflammatory. The idea behind stem cells would be kind of the holy grail. If we can get tendons and joints and cartilage and everything to heal, we're just not quite there yet. I think we're working on it, though. When you talk about people, or you hear, celebrities and stuff will go over to all these other countries and get, different fetal-derived ones, umbilical, because there's less restrictions. Again, there's just not a lot of science on that. Some people swear by it, though, and I do think there's something there, but I just think we got a ways to go before it's something that we're just going to be openly advertising, exactly, and saying, hey, come here, this is worth your time and money. PRP is really the best option if somebody has the means, because, again, I like doing everything I do to be data-driven.
Yeah, that's really interesting, the PRP, and you're using your own platelets and things to be that healing factor. So that's really cool. So we have a couple of minutes left, but so you work with local high schools, right? And so what is that relationship like?
Yeah. So we have a lot of good athletic trainers that we employ at Willis Knighton, and so we have contracts with the high schools where we actually provide them with these athletic trainers. So they see all the sports, they'll see kids that are injured, they help triage getting them into us, they can do local treatments and training room, they're the ones taping them, taking care of them primarily on the sidelines. And so that's kind of our relationship with the community, with sports medicine, especially with the high schools. Now, from my standpoint, I'll go cover some football games, and some of my partners will go out there, so we're extra sideline care. We let the trainers run the show, but if somebody goes down, it's a significant injury. We have great EMS and firefighters usually present, but if you need somebody helping with those more dramatic injuries that need to be carted off or taken to the ER, it's always good to be an extra physician on the sideline that you can help out with those things. So that's kind of our relationship. And then the injuries that do happen, I'm more than happy if I'm there. I can chat with the parents already, kind of tell them what I'm thinking, get them in, provide that service. We do Saturday clinics all throughout football season. It's a free clinic. We get kids in, try to keep them out of the ER, get them triaged, get them taken care of. So ideally they don't have to wait around all day and they can see an orthopedist and get a good answer.
That's pretty cool. I love that. Yeah, I love that. Cool. Okay, so just a couple minutes left, but if someone's watching and they're curious and maybe they want to get in to see you, are you accepting new patients right now?
Yeah, we're always busy. We'll get you in as quick as we can, between me and my great partners. Like I said, we're always happy to see new patients. I'm happy to work with you. I always tell patients, look, even if you come in and I'm triaging you and I'm trying to figure things out, and I'm saying, look, this is not really my specialty. This is actually something different. I'll let you know. We'll get you a plan. We have a lot of good people that will take care of a lot of different needs in town, so we'll get you to the right people.
Okay. And where can people find you? Where are you located? Your phone number, all that jazz.
We're at the Orthopedic Clinic. We're in the Portico Center, right across from Piermont Hospital. We have a website that you can find us on. Our phone number, our general line for our clinic, and everything is on there. And give us a call. We'll get you in.
And it's right there on your screen. The number 318-212. Gosh. Need to squint a little bit. 3610. And that's TOC Shreveport, right? The
Orthopedic Clinic. Yep.
Shreveport. All right. Well, good deal. And Mark Callanan, orthopedic sports medicine surgeon. Okay. And do you have anything? All of your information will be on that website as well. If If
everybody wants to see my bio, my training background, stuff that I've done, everything, all of our providers, you can go through and look at them, look at patient reviews, do all that stuff, look at backgrounds, all that is on the website. Okay,
good deal. Well, this was really interesting information. And if you missed this conversation, if you're just tuning in, all of this will be on our website, ktbs.com/podcast. It will be posted as a podcast, so you could listen to it that way as well. But thank you for joining us, Dr. Callanan, and thank you for joining us. And we hope you have a great day.